Hello, so this presentation is going to cover a PowerPoint on the topic of medication reconciliation. This particular PowerPoint was put together by a pharmacist by the name of Peggy Choi. So what is medication reconciliation? What is it? What does it do? Well, medication reconciliation is the process of identifying the most accurate list of all medications that a patient is taking, including that medication name, its dosage, the route, and the frequency at which the patient is to take that medication. And then we're going to take all that information and we're going to compare that list against a physician's admission, transfer, and/or discharge orders to avoid medication errors, such as omissions, dosing errors, continuation of an incorrect medication, or maybe a duplication in therapy. And this second part here of comparing that list, that is the actual reconciliation part of the process. So here's a little bubble diagram of medication reconciliation process. Now it can begin in any one of these bubbles in this little illustration here. However, most commonly, it is generally going to begin at the emergency room department, or maybe even the ICU. Maybe the patient wound up in ICU without going through emergency. By the time they get to the patient care floor, their medication should be evaluated because things that they needed on that acute emergent basis situation through the emergency room department and/or the ICU, those things may not be necessary any longer. Patient may be getting back to a more normal regimen, so their medication should be evaluated there at that point. Maybe the patient didn't go through the ER, so there was no need for the ICU. They never went to the patient floor, but maybe they experienced a situation that might have required some rehab, or they went through an outpatient clinic. So that is another instance in which the medication reconciliation process can be initiated or performed. And also in the patients at home, they don't necessarily have to have an incident. Sometimes a retail pharmacist may notice some things about a patient's profile and reach out, offer the service, call that patient in. Maybe they see the need for it, things of that nature. So it can happen while that patient is at home as well. So why is medication reconciliation so important? Well, because it can lead to adverse drug events, or ADEs. And these account for 4.7 of admissions to U.S. hospitals. Hospital costs related to ADEs run around 3.8 million US dollars per hospital per year. That is, again, per hospital per year. So that is millions of US dollars, which are preventable. And these medication errors, as I mentioned, lead to these adverse events. So 60% of all medication errors in the hospital occur at admissions, or during the intra-hospital transfer, or even at the discharge of the patient. And most especially so at discharge, because the patient then is probably a little confused as to which medications they can continue, which ones are new, are they supposed to keep taking? Well, now that I'm taking this, do I stop that? So that can lead to some confusion and medication errors there. And 53.6% of patients have at least one unintended medication discrepancy. That's a lot of people. 53.6% have at least one unintended medication discrepancy. That's a lot of medication errors. So we're going to look at a very particular hospital, UIC, and they created this RX Cares project to address these medication errors that were leading to the adverse drug events. So they took inpatient adult internal medicine at UIC Hospital, and they created a comprehensive medication reconciliation, or provided this service for some of their higher risk patients. Now, they had this service be performed by the 4th year pharmacy students during their medication rotation. So they're in their clinics, they're getting those practical experience hours, but they're not yet, pharmacists on their own. They are still working under the supervision of someone else very closely. Why do you think they would do that? Just think about that for a moment. How about the fact that these 4th year pharmacy students, they've got the information, it's brand new to them. They're generally going to be more cautious than a pharmacist who may have been doing this for years and has become complacent. So that's a really good reason why they might use a 4th year pharmacy student to perform this service over a pharmacist that might have been working in the field for 20 plus years. Just you tend to get complacent after you've done something for a long time. And the same is true of our pharmacists, unfortunately. So they included the admission and discharge reconciliation, as well as a follow-up phone call once that patient was discharged home to, see how they were doing, double check on those medications and where they were at on them, things of that nature. Excuse me. So the Module 1 data of the RX Cares project, included 5 weeks of data and information, or they performed this over a 5-week period. They utilized 4 of those 4th year pharmacy students, and those students screened 348 patients, of which 75 qualified for this service, meaning that they had enough medications, they were seeing enough doctors, insurance and other various factors come into play. So they wound up with 75 qualified patients. The number of changes to medications prior to admissions came to 614 medication changes for those 75 patients. And the number of changes to inpatient medications came to 69 out of 75 patients. And they found 57 discharge medication errors. And again, we are just looking at 75 patients. So you see a lot of changes, a lot of errors, a lot of things going on with these individuals. So the types of interventions that were made through this medication reconciliation process included additions. That's medications that the patient was on that were not included on an admission list. May have been, and it can be, doesn't have to necessarily just be prescription medications. This can include any herbals or vitamin regimens that they're on as well, over-the-counter products that they take regularly, especially if we're talking about like geriatric patients who might be on an 81 milligram aspirin or something of that nature. So additions refer to anything that the patient claimed they were taking that was not currently on an admission list. Deletions were medications that the patient was no longer taking, but that were still on the list. You ever go to the doctor and they're running down, are we still taking this, that, or the other? And sometimes those medications that they're going through on that list, like, you haven't taken that. Like I told you, the last 4 times I came here, I'm not taking that. I haven't been taking that kind of thing. So they need to get those medications off of their records. Duplications could be that maybe you're taking a new combination, or maybe the patient's taking a new combination medication, so they no longer need to take that single source medication. And maybe there was some confusion, and so they're taking both. So they have a therapeutic duplication whenever that happens. Or it could just straight up be the identical medication. It could be that they have a brand name from one pharmacy. Some of these people don't all fill their medication in one place, and maybe they filled the generic somewhere else. So they literally have the identical drug. That is still a duplication. They also addressed incorrect dosing through this process. We talk fairly frequently in the classroom about how the doctors will, I want you to increase this medicine, start taking one twice a day. So now we're going from 1 a day to 2 a day. However, the doctor will fail to or forget to address the fact that he needs to issue a new order now that he has made a dosage change. So we address those dosing errors such as that as we go through this medication reconciliation process. So how does the process work? Where does it begin? That sort of thing. So the process begins with a thorough medication history. And that's where, as pharmacy technicians, we most generally come into play. We are going to be the ones gathering those histories, reaching out, getting the information together. So the value of having a pharmacist or pharmacy student perform that medication history over another individual, we discussed earlier when I was talking about, number one, they're still in training, so they're being more cautious. They're a little more diligent than a pharmacist who may have become a little complacent. And these individuals, this information is still new to them. They're still highly, highly interested in the drugs. They're still learning information on each and every one of these drugs. So it becomes not just about obtaining a list of medications for a fourth-year pharmacy student. This is sort of a research project. And for somebody that's passionate about this sort of thing, this can be very fun for them if this is what they're passionate about. And to be a pharmacist, you need to be passionate about the drugs themselves, the chemicals, how they work, this, that, and the other. So you'll find a lot of your pharmacists, not only do they not mind doing these medication reconciliations, but if you can hollow out some time for them to do so they actually, most of them enjoy it and will be quite thorough at it. So as a pharmacy technician, again, sometimes we will be involved in the interviewing process, the gathering of information process. So let's address some tips to interview a patient. First, before you ever go into the patient's room, if you're doing this in a hospital or institutional type setting, you want to do your homework before you ever even go in there. And that means reading through admission notes to find out any past medical history, find out what brought them to the hospital on this particular occasion. What was their chief complaint? Did we fall, have a hip break? Are we here because of, adverse drug events? Some of these medications are starting to interact, cause problems. Does the patient have a cold? What brought them in? Then we want to look at, could any of the patient's medications have contributed to this hospital admission? Even something like a fall and a hip break, that could be medication related, especially in your geriatric patients. Some of the duplications of these various medications and things can cause some equilibrium issues for those older individuals and things of that nature. Some of overlapping of medications can cause things like dizziness, lightheadedness. So if they stand up too quick, or maybe they were, piddling down the hallway and just ever got slightly stumbled up, but because of the dizziness, they wound up going all the way down, sort of thing. So don't rule out those physical issues as, well, that's not related to medication, because sometimes they are. We also need to look at the patient's allergies that are on file, if any, with relevant reactions. Is the complaint that brought the patient to the hospital, is it due to a medication reaction? Not necessarily an adverse drug event. It could just simply be a side effect or even an actual allergy reaction to the medication. And is there an existing list of medications in the patient's chart? If so, we really need to evaluate that list because patients go home from the hospital, they go back to seeing their primary care physician. They will make adjustments, changes. Okay, I see where the hospital was going with this, and they will continue that care and therapy. So things change, especially once that patient returns home. So then we want to use that list as a starting point, but realize it may not be the most accurate, up-to-date list. It is just our starting point. If you're in an institutional setting, there may be an EMR or electronic medical record that can sometimes hinder an accurate list, because we see it electronic, we take it, true to heart faith that this thing is accurate and correct, and that may not always be the case. And sometimes with those EMRs, it takes a little bit longer to get the change updated into the system too, which can also be a bit of a hindrance. If there is a pre-existing list in the chart, or again, an electronic medical record list of some kind going on. Some healthcare providers in the process may just assume that it is current and not take the time to confirm or update the list with the patient. Remember, when a patient's in a hospital, they're seeing quite a few people. They may be seeing nutritionists, they're seeing those nurses, the orderlies, the doctors. I mean, there's a lot of people that goes through those rooms when they're in the hospital. So when we're trying to put together this medication history list or find out which medications the patient is currently on, I'm sorry, I'll get that slide straight. We need to consider some of the sources that we get our information for this history. Really great source, if the patient is cognitive and able to do so, is going to be the patient themselves. Hopefully they know their medications well enough to discuss this with you. If not, we may need to lean on a friend, grab a family member or somebody that might be helping this individual with their medications. I know in the case of my own personal mom, she handled my grandmother's medications as if they were her own and probably knew much more about them than my own grandmother did. So, you know, in some cases with family members, and you're talking about geriatric patients or maybe even a pediatric patient, that family is going to probably know more about the medication than the actual patient. And of course, it could just be a caretaker. It might not even be a family member. It could be a hired caretaker even. And, you know, again, they're with that individual day in, day out, helping them with daily activities. So sometimes these people know much more about the medication than the patient themselves. They know why it's taken, when it's taken, you know, so on and so forth. And of course, the pharmacy where the patient fills their medication. Hopefully, if that patient is utilizing one single pharmacy, then most everything you need is going to be all in one place. The pharmacy can look at dates and fill histories and determine which medications have been discontinued and things of that nature. And if the patient is at a nursing home or assisted living facility, that facility or home may have records of medications as well. So when it comes time for the actual interview, you want to make sure first and foremost to introduce yourself, right? Who wants to answer a bunch of healthcare questions about getting real specific and personal about their medications, and you haven't even bothered to tell them who the heck you are. So we need to start that interview process with introductions. Tell them why you're meeting with them, that you would like to ask about their medications they were taking before they came to the hospital, or maybe you're in a retail pharmacy setting. So, you know, before you came in today would be another way to address that. And it's likely, especially if they're in that institutional setting, it's going to be very likely that you are not the first person to ask them about their medications, although you may be the most thorough, which is another reason why it's important to keep doing this again and again and again. So what if the nurse asked them about this 2 hours ago? Now I'm in the room and I need to make sure that she documented her notes properly, you know, that sort of thing. I use the reference of, most of you have heard a lot of my history, but I've had both of my feet operated on. Both times I went to have my foot operated on, my foot doctor would question me before they ever administered the first bit of medication. Which foot are we operating on today? The man would even take out a permanent marker and draw an X on the operative foot. And it wasn't because he was incompetent, that he couldn't remember for more than 5 minutes that we're operating. That's a part of safety and procedures to make sure, you know, to help eliminate the human error. Because as long as humans are present, there's going to be some degree or level of error. And we can reduce that degree or level of error by taking what seem like idiotic steps, such as putting an X on the surgical foot kind of thing. And I know we're talking medication here, but hopefully you're getting the gist. And, you know, and again, as it's mentioned here about how you may be the most thorough, although each and every practitioner that steps into that patient's room may be questioning them about their medications, no two people are going to go about it quite exactly the same way. So somebody's going to be more thorough than the other in some ways, and then maybe vice versa in other ways. So you pick up various tidbits from each and every, and it's not that, you know, hey, maybe this person shouldn't be conducting interviews, or maybe they shouldn't be involved in the medication reconciliation process. Each party is very important. So as I mentioned, although you're being really thorough, there could be something that you missed over that they had covered. So each party is very important in this process. So if that question, if the patient questions, why is everybody coming in here and asking me these same questions? We need to acknowledge this, that I'm sure others have asked you about your medications, but my job is to ensure that we have the most accurate list so that we can have you on the correct medications while in the hospital. And it's a nice, polite way, roundabout way of explaining to that patient, I realize this is probably annoying. You keep having to answer these same questions to each and every one of us that come into the room. We're doing this though with your safety in mind. And a lot of people are willing to tolerate annoying things if they understand why it's occurring. So most patients, as I just mentioned, are going to appreciate that fact rather than be annoyed that yet another person's asking them about their medications. So you want to try during this interview process to ask questions in a way that lets that patient tell you what medications they are on and what they are for. So we're asking those open-ended questions. We're going to avoid any questions that can result in a simple yes or no kind of answer. So an example here, a bad question would be, do you take albuterol? You're giving that patient information when you ask that sort of question. You're already giving them a drug name. So a better way to word that would be, can you tell me what you take for your asthma? When and how often do you use it? Because you're trying to find out too, through the process of this interview, how well the patient knows their own medications. You would be surprised how many people really don't know their medications very well. So these open-ended questions are going to allow you to assess their knowledge of their own personal medications. However, you can certainly help them along if they're not as knowledgeable, especially, when we talk about our geriatric patients. A lot of your geriatrics are just simply going to know that they take that yellow pill in the morning while they're eating breakfast. And that little red pill is the one that they take with their lunch. And at bedtime, they have that little bitty, oblong looking blue pill kind of thing. That is a lot of your geriatrics are going to be that way. So when they start talking colors and things, you might even have to use an app so that you can be trying to pill identify as you go through and compare to figure out, and you will give them hinters and clues if that's what it's come to. You also want to be sure to ask about any over-the-counter medications, herbal supplements, those vitamins. Like I said, that 81 milligram aspirin that a lot of people will be taking. Ladies, there's those hair, skin, and nail vitamins. Now we have collagen and other things that we're taking. All that stuff's available over the counter. Also, you might need to find out about some of their dietary habits as well. If you have a patient who is on a anticoagulant, such as Coumadin, which goes by the generic name of warfarin, you need to find out if that individual is eating green leafy foods. How often are you eating salads? Do you eat much broccoli? Things of that nature, because that's going to be counterintuitive to the medication. Some medications aren't supposed to be with real acidic foods, such as grapefruit, stuff like that. So sometimes you might even, depending on the medications in play, have to delve off into some of those dietary things as well. So we want to assess the patient's compliance in a non-threatening manner. We don't want them to make them feel bad if they're having to tell you, well, no, I haven't really been taking that the way that I'm supposed to. You don't want to be like, oh my gosh, well, why? I mean, it's a waste of the doctor's time to prescribe it. The pharmacy took time to fill it. And yes, sometimes it gets frustrating and you may want to inside be doing that. Like, well, then why are you even filling it, kind of thing. But we don't want to let the patient see any of that. You want it to be non-threatening. You want them to feel comfortable during this interviewing process. You want to get them to where they'll kind of sort of open up to you and maybe tell you things that they wouldn't tell their doctor, so to speak. So we need to find out what issues might prevent you from being able to take your medication regularly. Not, are you, how, how diligent are you about taking your medication? And a better way to go about that would be, are you running into issues that keep you from taking your medicine regularly? And you would be surprised on the answers that a question such as that could bring about. It could be mobility issues. They can't get to it in the cabinet. When my daughter came over and she put it up there too high, now I can't get to it. Could be the pharmacy mistakenly put a child safety cap on it, and the patient may have severe arthritis, so she's struggling just getting in and out of the bottle on a regular basis. It could be a financial issue. So there's a variety of things that can keep a patient from taking that medication regularly. Some of the side effects may give them a funny taste in their mouth, or I notice when I take that, I get gas, or just various things will keep them from wanting that medicine. And we also need to find out, well, about how many times per week do you estimate you miss your dose? If they do miss, we need to find out why. Again, is it financial? Are we having some side effect issues? Something else going on? And we also need to find out, is that patient managing their own medications, or is there, a family member or a caregiver that maybe comes by and tends to that once or twice a week, or whatever, however frequent it's necessary. Excuse me, sorry. And of course, through the course of this interview, we are finding out and assessing, is that patient able to comfortably afford these medications on a monthly basis? If finances are becoming an issue, we may need to see about some cheaper alternatives. We might need to see if we can get the patient set up on some programs that might could assist them with the cost of those medications. So there's some options available there. And again, find out if it's any troubling side effects that make you not want to take the medication. Is it causing too much nausea, blurry vision, et cetera, et cetera? We need to get to the bottom of those types of things. So what if the patient is unable to tell you what medications they're on? Could be that they're in a coma. Could be that they have a tube down their throat. We're talking about ER, ICU patients here. So they're not always able to speak. Could be whatever ailment has brought them in, has them in a state where they can't speak. Could be post-surgical and they haven't woke up enough, kind of thing. There's a number of reasons why they might not be able to talk to you directly themselves. So when that's the case, we may need to seek alternative sources of information. That's when we're going to turn to those family members, caretakers. We want to try to go to the patient's primary pharmacy or pharmacies if they're one of these people that likes to use more than one pharmacy. Again, if we're talking about a geriatric patient, we could be looking into some nursing home records, check with that primary care provider and any clinic records that we can get our hands on. And sometimes you can kind of sort of, puzzle piece together some sort of a medication list without the patient even being involved. You may need to use multiple sources if the patient is unable to be involved. So you're talking to that family member and you're reaching out to the pharmacy and you're talking to the nursing home and you're talking to that primary care provider, because we want to get and obtain that most complete list and assess their compliance. Compliance being, are they taking that medication regularly as prescribed for what it's prescribed? And then the reconcile portion, where we're actually going to reconciliate this list. This is where we take that list of that medication history list that we have now put together, and we're going to compare that list to what is currently ordered for the patient in the hospital. Now, this portion is the sole duty of the pharmacist. The pharmacist is the one who will do the actual reconciliation. Pharmacy tech can gather all the information. They can get all the patient history together. They can log information. There's a form that we will address where we can log down all this information and such. And we can compare that, or we get that together, and the pharmacist, I'm sorry, is the one that is going to reconcile it or compare that list to what is currently being ordered for the patient in the hospital. They're going to check for any omissions, dosing errors, continuation of medications that the patient may no longer be taking at home. They're going to look and see if there's any drug interactions between the various orders. And they will also see if there's any disease interactions Some of these medications are not really meant to be taken with various diseases. So remember, some dosing changes may be intentional due to something acutely occurring with the patient. Excuse me. Such as a blood pressure is acutely elevated, so doses of their antihypertensives have been increased to accommodate that issue. Or it could be that the patient is dehydrated, so their home Lasix, which is a fluid medication, is being held and they are receiving IV fluids. If somebody is dehydrated, we don't want them excreting what fluids their body has. So you would hold off on their fluid retention medication. And then the final steps is to update the medication list and the medical record. Make any deletions that need to, take out those medications that were on our original list that patient is no longer taking. We're going to add or correct medications that the patient is currently taking. If that dosage changed, we're going to make sure that gets notated properly. If the medication changed entirely, we need to get that notated properly. Then we're going to communicate the discrepancies that were found to the patient's prescriber. And it says after discussing with the preceptor. Preceptor would be who is overseeing that 4th year pharmacy student. So if it's a pharmacist that's already graduated, there will be no preceptor involved. Just wanted to clarify that. So to summarize our medication reconciliation, we need to first review that patient record prior to the interview. Then we're going to conduct that medication history and the interview itself. The pharmacist or pharmacy student will reconcile that list of medications obtained from the history, and they're going to update the current list in the medical record. And we're going to communicate those discrepancies to the patient's prescriber. So they give you an example case here of a 65-year-old male with congestive heart failure, only about 30% effective, coronary artery disease, that's what CAD is. There's hypertension, HL with a recent DVT that was diagnosed 2 months ago, DVT being deep vein thrombosis, and OA admitted with SOB being shortness of breath. So you see, we've got some things going on here, some various findings, exacerbation of that congestive heart failure. So we have a home medications from a recent discharge note in the patient's chart that consists of carvedilol, valsartan, warfarin, atorvastatin. ASA is the abbreviation for aspirin, clonidine, metoprolol, and Aleve. So a lot of you are still learning your medications. You're not able to see what I can already immediately see in this list. But you see this medication here ends in LOL. Y'all hear me all the time tell you that beta blockers are funny. That's because beta blockers in the generic name ends in LOL. Look down here. Here's another LOL. So we have another beta blocker. It's not the exact same medication, but they are in the same class of medication. So they work very, very similarly and are basically going to achieve about the same thing. Valsartan is an A2RB, which is also for blood pressure. So we have 3 blood pressure medicines right there. And then this lovely gem right here, clonidine. Clonidine can be used for a couple of things. One of the things that it is used for, however, is to bring blood pressure down. So if you have a really high elevated blood pressure, they will give clonidine to get that blood pressure into check very quickly. So there is a 4th blood pressure medication. As I mentioned, warfarin is the generic of Coumadin, which is an anticoagulant. So it's going to keep those blood platelets from collecting together and clotting. And aspirin is also an anticoagulant. That's why you will see a lot of your elderly taking that 81 milligram aspirin daily. It's not as strong as the warfarin by any means. It's very weak because it is over the counter. But aspirin in general will thin the blood a little bit, making it easier for it to circulate for your patients that have heart issues and so on and so forth. So we have two different medications here. So if this patient cuts themselves, they're going to have a really hard time clotting that up. Aleve is an NSAID, a non-steroidal anti-inflammatory drug. Non-steroidal anti-inflammatory drugs are contraindicated with anticoagulants. So they should not really be taken together. You have a patient who's on an anticoagulant and they have a headache or something of that nature, they should be taking something like Tylenol. So that's just as a pharmacy technician, some of the big things I see right out the gate there. And then we have the atorvastatin there, that's going to be for cholesterol. I don't really see any interactions going on with it. They do notate here that there is no diuretic in this medication list, and there is not, and that the patient probably has a fluid overload. So what they did for this individual was they gave this patient some IV Lasix and admitted them to the floor. That IV Lasix is going to help with that fluid overload that was going on. There are some relevant lab values here that a pharmacist would evaluate to see how those anticoagulants are working. Are they doing their job? Is the blood too thin? Is it still too thick? Where's their glucose, and so on and so forth. So here is what wound up happening after the medication list was reconciled. They left the carvedilol alone. The patient's taking it twice a day. The metoprolol was changed to carvedilol at the last admission, so the patient's no longer taking that metoprolol. It was replaced with the carvedilol. They did, however, leave the patient on the valsartan. It is a different type of blood pressure medications, so that is viable. They clarified how often that anticoagulant was taken. The patient was doing it on Mondays and Fridays. They were taking 2.5 milligram, and due to their lab values and such, the patient was sent home with 5 milligrams daily. That cholesterol medication, the atorvastatin, you see there was no changes really made there. They left the patient on the 81 milligram aspirin, because again, it's so mild. The clonidine, they had a notation here that the patient was no longer taken. They must have gotten that blood pressure into check. And then I'm not sure why the naproxen remained. Then they have a notation here for osteo, but DC, the warfarin, bleed risk, duplication of NSAID, not used in AKI. So they at least made a notation here regarding that NSAID. They also have a note over here referring to how to hold that valsartan due to these concerns and to restart that warfarin dose based on INR. So that is what it looks like after it has been reconciled. So I hope this has been clear for you. I know this last little part probably gets muddy. And again, it's mostly because as a pharmacy technician, we might be providing some of this information to the patient, but we should never be the ones actually performing the reconciliation. That is the sole job of the pharmacist. And that was my PowerPoint presentation on medication reconciliation. If it is still confusing, I can put it to you this way in a little bit of a nutshell. You're basically compiling a history list of the patient's medications, what medications that patient thinks they're on, what medications the doctor thinks that the patient's on, what medications that the hospital or facility thinks that the patient should be on. And you're taking those lists, you're making one big list, and then you're going to turn that over to a pharmacist, pharmacy student, pharmacist intern, who will then go through that list with a fine-tooth comb, looking for those drug-drug interactions, looking for those drug disease interactions, looking for those duplications of medication therapy, and they're going to clean that list up and get it back to the patient and that patient's primary provider, as well as the facility records or whoever else, wherever the entity is. We're trying to clean up that list, make sure that there are no dosage errors within the list, make sure there's no duplications of medications within the list, and make sure that there are no drug-drug interactions within the list and no disease-drug interactions. And that's really all we're doing, is scrubbing through a list to make sure that the patient's safety is covered and that we're not overdoing things. So I hope this has been clear. There will be an assignment to go along with this. And until we see each other again, bye-bye for now.